Hello, I'd like to welcome you to the GAP MASLD MASH Community Network. I'd like to thank our sponsor, Madrigal, and the organizers for the opportunity to speak to you about non-invasive testing. My name is HoChong Gilles, and I am a nurse practitioner at the Central Virginia VA healthcare system and have been working in hepatology for the past 25 years. So thank you for attending. So if you could use the QR code to record your attendings for this meeting, that would be wonderful. And then what we'll do is there is another QR code if you are interested in visiting the GAP MASLD MASH Community Network to view the MASH disease state education and Madrigal's Rezdiffra promotional program. These are excellent programs, so please check it out. So to help contextualize a typical patient that we see in our clinic that's referred for an assessment for suspected MASLD. So you have Albert, who is a 65-year-old male with obesity that's referred for elevated liver tests. And his abdominal ultrasound is remarkable for increased echogenicity consistent with steatosis. So he's 65, again, he's Hispanic, and his BMI is 29. He does not have alcohol history, which is important to exclude. He does have type 2 diabetes, hypertension, and hyperlipidemia, which are 3 cardiometabolic risk factors. His laboratory shows normal triglycerides. His hemoglobin A1C is not at goal, but is reflective of his diabetes diagnosis. His ALT with known elevation for the past 3 years, which has been at the 1 to 2 upper times limit of normal. His valuation for other causes of chronic liver disease is negative because you want to make sure you should exclude other common causes of elevated liver enzymes. And also knowing that you have the presence of steatosis with cardiometabolic risk factors, you suspect that this patient is likely going to have the diagnosis of a MASLD. Now, he does have abdominal adiposity. He has no stigmata of advanced liver disease, which is important because you want to make sure that you don't see any obvious signs of overt cirrhosis. And again, I mentioned that his BMI is 29. So the next question is, does Albert have significant fibrosis? So the landscape of non-invasive assessments of liver disease in 2025 is quite broad. Generally includes imaging markers for fat, which includes ultrasound quantitative techniques. And if you recall, he had steatosis on ultrasound, and oftentimes it's found in, incidentally. You have MR spectroscopy, but it's not always used and are readily available. We do have the CAP, which is part of it's called the controlled attenuation parameter of the VCTE, which I'll discuss. And then we have the MRI, which is the proton density fat fraction, which can estimate a percentage of hepatic steatosis. We do have imaging biomarkers for liver stiffness that includes shear wave elastography, RFE. The most common is VCTE, and then of course we have MR elastography. We do have clinical prediction tools that are used to detect or screen for fibrosis and risk stratification. We have the FIB-4 score, the MASLD fibrosis score, and the APRI score. We also have proprietary serum markers for fibrosis, which include ProC3, the enhanced liver fibrosis, also known as the ELF FibroSpectrum fibrometer. And finally, we have, combined rules that utilize results of imaging biomarkers, serum values, or other clinical prediction tools. And for today, we'll be focusing on the specific non-invasive tests that are highlighted in gold. So the FIB4 index is pretty simple and it's accessible, and some EMRs even have an automatic calculation for the FIB4. It is a non-invasive test that utilizes the AST, the ALT, the platelet count values, and in combination with the patient's age to assess whether a patient has a low or a high probability of advanced fibrosis. This was developed by a friend of mine, Dr. Sterling at VCU, and because of its simplicity and accessibility, it's often the first non-invasive test that's applied to patients with MASLD for risk stratification. Now, we have proprietary serum markers called the ELF score, which is the Enhanced Liver Fibrosis score. It is a marker of active fibrosis development, and it is essentially markers of using hyaluronic acid, the tissue inhibitor of metalloproteinase 1, and the P3MP. Now, and these markers are really, they signify matrix turnover, a marker of active fibrosis development, and the ranges results between 7.77 and 9.8 are consistent with significant fibrosis. Now, there's been major advancement in non-invasive assessments of liver disease using liver stiffness as a biomarker of fibrosis. Stiffness is the ability to essentially of an object to resist deformation in response to an applied force, which is typically a transducer. Okay, and then what shear waves travel faster through a stiff liver, and liver stiffness increases with fibrosis stage. So it's a surrogate marker for fibrosis. This slide shows the imaging differences between transient elastography, also known as FibroScan, and to the upper right, you have a nice imaging of what you can see when you order an MR elastography. And then the two studies below on the bottom are point shear wave and 2D shear wave elastography. The difference between the 2D and the point shear wave is the main difference is really that the stiffness on the point shear wave elastography is directed at one point, and as you can see, the transducer here, whereas in the 2D shear wave elastography, the operator can actually modify and select the region of interest to obtain real-time samples of stiffness maps. So vibration-controlled transient elastography, also known as the proprietary name of FibroScan, is really the most often used imaging biomarker for liver stiffness and steatosis. It's essentially our hepatology point of care testing that, involves the acquisition of a pulse echo ultrasound through that transducer here. And then there are different probes. You can see the two different sizes on this little hook there on the right of the machine. And then that transducer is applied and you develop a pulse echo that signals to measure liver stiffness. It also includes a measurement for steatosis as well, using what they call the CAP score, which measures the attenuation of ultrasound waves as they pass through the liver and compares it to the normal liver. And fat in the liver absorbs more of the ultrasound signal, which reduces the amount that returns to the probe. And the CAP score has a range between 100 and 400 decibel per milliwatt, and the liver steatosis is really defined as a median CAP score of approximately 236 or higher. So I always say around 240 is the presence of a liver steatosis. So, but there are some exam considerations when you're using the FibroScan. To the image to the right, it shows the propagation map of a VCTE exam, and you want to see that nice parallel shear wave margins when you're evaluating the results. And, you want to make sure are there 10 valid measurements. So sometimes you can't just look at the numbers at the VCTE to make a clinical decision. I think you need to assess the quality of the exam And ask, is the operator experienced? In our practice, we have a nurse that is consistently the one performing the FibroScan. So you want to make sure, was there a success rate in obtaining 10 measurements? So even though there are 10 maybe valid measurements, did it take like 25 times to get those 10 valid measurements? And also you want to make sure that the interquartile range, the IQR median, is less than 30%. And it's really want to make sure that you don't want to make a clinical decision based on poor data. So you want to make sure that there are some considerations when you're assessing these scores. So it's also important to consider that there are some limitations to VCTE. There are some confounding factors that can over or underestimate hepatic stiffness. Laboratory, and most of the time it's an overestimation of hepatic stiffness. You have laboratory factors. So if you have someone that has very grossly elevated, liver enzymes and has active hepatitis, that can also overestimate hepatic stiffness, or if they have underlying cholestasis. There are also patient factors. It's important that patients fast at least 3 to 4 hours before testing. Sometimes it can give you discordant results, when someone is using, fluoride alcohol use. Sometimes body habitus can limit the exam, especially for those that have morbid obesity. And of course, with ascites or liver masses, it can skew the results. So MRE, or MR elastography, is essentially a proprietary software that utilizes shear wave technology. It places an acoustic driver on the patient and it produces images that are called elastograms, that are quantitative multicolor cross-sectional maps of liver stiffness. As you can see, the hot areas there in the liver are red, and green is, I always think about, the traffic lights, green, yellow, and red. And some considerations when ordering MREs, that it's not sometimes feasible for someone with high BMIs. Most of the time, patients with a BMI greater than 40, I also have to look at their shoulders, because their shoulders, they have to fit into the machine. Also considerations if you have someone with iron overload, or you have to make sure safety, that they have compatible implants if they do have implants, claustrophobia. If they have hepatic, congestion, again, like if they have heart failure, maybe not, order an MRE, because it can give you discordant results, and it's not always accessible, and there's always insurance issues. So this slide really compares a lot of the non-invasive biomarkers that we use in clinical practice. These have good established, cutoff points of either ruling out significant fibrosis or ruling in significant fibrosis. The FIB-4, if you have a FIB-4 less than 1.3, it's considered low risk. Again, it's pretty feasible. But if you have a FIB-4 greater than 2.67, is highly concerning for advanced fibrosis and warrants further testing, and often referral to specialty care. But the NICE, it does have good established high negative predictive values. Again, the serum biomarker, if you don't have access to VCTE, is very helpful. The enhanced liver fibrosis. The rule out cutoff is if you have an ELF score of less than 7.7, and of course the rule in cutoff is greater than 9.8, and numbers in between is pretty much assesses indeterminate scores. It is a send out test. It can be costly, and sometimes some insurance payers are not paying for it, but one of the strengths of this exam, it has a high negative predictive value. So we spoke about the imaging fibrosis biomarkers. The most importantly or commonly used is a VCTE known as FibroScan. The cutoffs here for kilopascals is again a surrogate for hepatic fibrosis. And if a KPA is less than 8, it's considered low risk. And a ruling cutoff for advanced fibrosis is greater than 12. So one of the things I always try to remember is, especially when we're going to talk about, potential future pharmacotherapeutics that are available, I always look for, because we're trying to identify those with F2 and F3 fibrosis, I always kind of talk about the sweet spot between 10 to 15 kilopascals. But that we did discuss the potential confounders of the FibroScan, and also it is operator dependent like any other ultrasound exam. The nice strength is that it is a point of care testing that is often found in many hepatology practices and GI practices, and it does have good, high established negative predictive value. The MRE is my go-to exam, especially if there's discordant results. The KPA cutoffs for those is less than 2.5 is low risk, but those with a kilopascal greater than 3.6 is concerning for advanced fibrosis. The limitation of MRE essentially is that you have to have the software. Even though you have MRI capability, does not necessarily mean that they have the capability of doing MR elastography. It's often, it's costly, just like any other MR exam. It is without contrast, but the problem is access. It tends to be, available only at major academic centers. So the access is not as great as other biomarkers that are available. But it is highly accurate because, you actually can visualize the entire liver, as you recall, in that heat map. And so that's some advantages because you're looking at multiple areas of the, region of interest. You're looking at the entire liver. So let's return back to Albert, who has, likely a MASLD. We need to decide, again, what are the steps to assess liver fibrosis? So we can confidently say that he has MASLD, right? Because he has a presence of steatosis. He has the presence of, medical, his history points to multiple cardiometabolic risk factors. We have excluded other forms of chronic liver disease, which is important, including the exclusion of a significant alcohol, because as you know, then you can get into, what they call MetALD. But, we did an extensive alcohol history, which is, I think, very important. And a lot of practices are using the long-term PEth exam to determine if there is significant alcohol use. Unfortunately, patients do tend to underestimate their alcohol intake. So, and then the key portion is that, he does not have, or key aspect is that he does not have any evidence of stigmata of advanced liver disease. So what would be your next step in assessing liver fibrosis? So, we have mild, transaminase elevation here, as you can see, with an ALT of 43 and an AST of 38. Regardless of your reference ranges and labs, in males, that ALT greater than 30 is abnormal. His platelet count is 170, so still a little bit closer to 150 than I like, but it is greater than 150. So we calculate the FIB4, and his FIB4 is 2.2 because you need these parameters, the ALT and the AST and the platelet count, and his age of 65 to calculate that FIB4 if you don't have it automatically calculated in your EMR. And so this FIB4 range, because it's not less than 1.3 and it's not higher than 2.67, this is what we would call an indeterminate range. So what we would need to do next is he's considered indeterminate risk. So what would we do here? This is a nice clinical decision tool that is was created by the AGA clinical pathway flow. And what's nice about this is a very algorithmic approach to patients. And first step is, identifying patients at risk. Again, having 2 or more metabolic risk factors, and he had steatosis. We looked at, we took additional labs if your patient didn't have it already. So we excluded alcohol. We did a CBC to get that platelet count, and then we did a liver panel so that we can get the liver enzyme results. We calculated the FIB4, and because it's in between 1.3 to between 2.67, we determined that he is indeterminate risk. And so what should you do next? Now they recommend the liver stiffness measurement and by using a FibroScan. We did do a FibroScan, but again, if you don't have access to FibroScan, then the next, in the guidelines, one of the next tests you can do is use the ELF score if you cannot get a FibroScan. But we were able to get his liver stiffness measurement, and it was 6.7 kilopascals. But because it's under 8, he is deemed low risk. So good, high positive predictive value, and he's low risk. And so what we would do is, remember, his hemoglobin A1C was 7.2. We really need to encourage lifestyle modification, which is still the cornerstone of MASLD care. We want to optimize his metabolic disease management, especially he has some room for improved glycemic control because his hemoglobin A1C was 7.2. And then because he is low risk, they recommend repeating a non-invasive test in 2 to 3 years unless his clinical circumstances change. So this is, the most common patients that we see. Luckily, the good news for him, he doesn't have significant advanced fibrosis, but there is a variety of non-invasive tests that can be applied in the clinical setting, and because we're going away from liver biopsy. So I thank you for the opportunity of speaking to you all today, and if I'll entertain any questions if you have any.
Thank you so much, HoChong. As HoChong mentioned, if you have any questions, please feel free to unmute yourself or type your question in the chat box.
Again, I would like to, if you don't have any questions, there is in the beginning of the presentation, which I'll go back, is the QR code for additional education. There's a lot more interesting data that's coming out from Madrigal with the data from the Maestro and NASH. And so there is a disease state education and also a promotional program if you want to learn more about Rezdiffra, which is the only FDA approved therapy right now for F2, F3 non-cirrhotic MASH. And so this is a QR code if you are all interested. So if I don't see any questions, and again, thank you to the sponsors and also GAP for organizing this event. I really appreciate it. It was a pleasure being with you today.